Hello, can you hear me?
Yes, Philip, we can hear you.
Okay, XYZZ Med is a vibrant community of Kenyan medical students from multiple universities, united by the mission to enhance medical education in Kenya. This initiative is driven by the need to create accessible, locally relevant, and tailored resources that directly address the country's unique healthcare challenges. The current medical education system in Kenya frequently depends on foreign resources, which may not always align with the local context. This gap leaves healthcare professionals less prepared and contributes to a lack of public awareness regarding various medical conditions. XYZZ Med is bridging this divide by developing a wide range of educational tools, including relatable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, etc., etc. One such initiative is this CME series, designed to promote peer-to-peer learning, as it's often our peers who can break down complex concepts into more understandable terms. Today's CME topic is colorectal cancer, and our speaker of the day is Jane Otieno, a fifth-year medical student at the University of Nairobi. And my name is Philip Oluoch, the moderator of the day. Welcome all. So in case you have any question, you're always free to ask at the end of the presentation by our speaker. You may note them down, and some of you might unmute. Some may present their questions in the chat box. I'll be able to air that to the speaker so that it can be addressed. Jane, the platform is yours.
Thank you very much, Philip. I hope I'm audible enough.
Yes.
Good morning. Okay, thank you. So good morning, everyone. Today we're going to talk about colorectal cancer. I know the weather is not very conducive, but bear with me. So colorectal cancer we're basically going to be talking about carcinoma arising from colonic or rectal mucosa. It's the third most common cancer worldwide, following lung cancer and breast, with prostate closely following as well. And it's the second leading cause of cancer deaths after lung cancer. It's the most common gastrointestinal malignancy, and the peak incidence is between 60 to 70 years. It has been more common in the West, but we're seeing increased incidence in our region, which there are thoughts that it could be attributed to the change in diet. And also we're seeing an increased incidence in younger age groups. And for those who get them, the younger patients who get colorectal carcinoma, it progresses more rapidly as compared to the older patients. So just a brief reminder of the anatomy. We're going to be talking about cancers that occur in the cecum, the ascending colon, the transverse colon, descending colon, sigmoid, and the rectum. And the layers of the colon are 4. We have the mucosa. From the lumen, we have the mucosa, the submucosa, the muscle layers, and subserosa and serosa if it's intraperitoneal, and adventitia if it's retroperitoneal. Some of the risk factors for colorectal cancer, we have older age, more than 50 years. As I've said, the peak incidence is 60 to 70. There's a slight male preponderance of a ratio of about 2 to 1. And family history of colon polyps or colon cancer is a very big risk factor, especially if you have direct family, so either a sibling, a brother, or the parents. And we also have the familial adenomatous polyposis syndromes, such as Gardner. We have the Two-Coat syndrome. These ones have an almost 100% risk of developing colorectal cancer by the time you get to age 40. We also have hematomas, such as the juvenile polyposis and Peutz-Jeghers. And then we have hereditary non-polyposis colorectal cancer, which is associated with a 40% risk of it developing into cancer. We have neoplastic polyps, especially the tubular or the villus. And then we have black race. We also have inflammatory conditions, such as ulcerative colitis and Crohn's, and especially it depends on the duration in which somebody has had them. A previous personal history of colorectal cancer. The main one I want to focus on today is diet. A low fiber diet, or diet high in red or processed meats, high fat content, refined carbohydrates, and low intake of fruits and vegetables. The fiber, the reason why a low fiber diet would predispose somebody to developing cancer is because fiber, normally they absorb the toxins and oncogenes that we'd have in the gut. So a low fiber diet is a very important and preventable risk factor. And then we have smoking and heavy alcohol use, and obesity and lack of physical activity as well. Some of the protective agents are dietary constituents, vitamin C and E, selenium, retinoids, beta carotene, and calcium, which are things that are readily available in the foods that we eat. NSAIDs are thought to be protective, especially aspirin, and this is because of its action of inhibition of COX-2. Most of the colorectal cancers produce COX-2, and the COX-2 is it causes epithelial proliferation. So its inhibition sort of slows down the rate at which maybe the polyps would develop into cancer. Physical activity is also protective, and diet rich in fiber and increased intake of vegetables and fruits. The pathophysiology, it's likely that all carcinomas start as adenomas, and then with mutations that occur, they end up developing into carcinoma. I'll talk about those mutations in a minute. The macroscopic varieties that we have are annular, which, let me just annotate, grow circumferentially, so around the lumen of the colon. Then we have the tubular. We have cauliflower, which is the least malignant form. And then we have infiltrating and ulcerative, which is normally associated with poor prognosis. And then we have microscopic types, adenocarcinoma, which is what contributes to more than 90% of the cancers that we have. Could be well differentiated, moderately differentiated, or poorly differentiated. Poorly differentiated, like with most of the other cancers, is normally associated with poor prognosis. The other types we could have are malignant spindle cell tumors, lymphomas, carcinoid tumors, squamous cell carcinoma, especially in the anal zone, malignant melanoma at the anal verge. Now, the pathways that I wanted to talk about, the mutation, we have three. The most important are the APC beta-catenin pathway, which accounts for 80% of sporadic colon tumors. So it's a stepwise sort of series of mutations that occur from the APC, which is is a tumor suppressor. And normally the APC binds and promotes degradation of beta-catenin. So if there is mutation in both copies of APC, we have beta-catenin accumulation, which will translocate into the nucleus and activate genes that promote proliferation. So basically, the mutation of APC impairs its role as a tumor suppressor. Afterwards, we have mutation in KRAS, which is a proto-oncogene, which when that happens, it promotes growth and prevents apoptosis. And then the next step would be mutation in SMAD2, SMAD4, which also lead to unrestrained cell growth. And in later stages, we have mutations in P53, which is a tumor suppressor. So the mutation will impair its role as a tumor suppressor and lead to, again, uncontrolled growth. And finally, we have expression of telomerase. So it's a stepwise sort of series of events. And then the other important one is microsatellite instability pathway, which accounts for about 10 to 15% of sporadic cases where we have mutation in DNA mismatch repair. And then we have the SIMP pathway, which is due to hypermethylation of CpG islands. It's important to know which pathway, or to try and find out what pathway the cancer has taken, because it will influence the type of management that you will give the patient. The most common site of development of colorectal cancers is the rectum, which accounts for about 38%. And then we have the sigmoid colon, and then the cecum, descending colon, ascending colon. So it can occur in any of those areas, but the most common is the rectum, followed by the sigmoid colon. Some of the clinical features that you'll see are change in bowel habits. So diarrhea or constipation or alternating between the two. We have blood in stool, persistent abdominal discomfort, bloating or cramps, iron deficiency anemia, which is a very important one, feeling of incomplete bowel emptying. Then we have the constitutional symptoms, fatigue, weight loss, night sweats. And we can have people who present with emergency presentations who will present with intestinal obstruction, and especially with the annula, because you see how it grows sort of circumferentially, it easily leads to intestinal obstruction. And then we have some can present with perforation and eventually peritonitis, and features of metastasis depending on where it has gone. So if it is metastasized to the lungs, we'll have dyspnea, chest pain. To the liver, you can have jaundice. They present with ascites. So again, usually this is late stage. And then now for specific, depending on the specific side of the colon in which the cancer develops, you can have different sort of presentations. So for right-sided, which is going to be the ascending colon and the cecum, let me just get to here and there, cecum, you'll have, it accounts for about 20% of the cases. The tumors grow on one, they usually are exophytic polyploid. They grow on sort of one side of the wall, but the cecum is also really big. So for the most part, you won't get them presenting with obstruction, but you'll get, because the cecum can accommodate a large size, the tumor will grow. And what will be able to be noticed clinically is a palpable mass in the right lower quadrant. They will present with weight loss, again, because the tumor can grow, and by the time it is going to be diagnosed, it's going to be at a later stage. The tumors have a tendency of ulcerating and bleeding. So they'll have occult bleeding, and they'll eventually present with iron deficiency anemia. So again, I said this was very important. The advice is, if you see somebody who's older than 45 or 50 who presents with iron deficiency anemia, it's very good to try and screen and see if there's a possibility they might have colorectal cancer. So you probably take a good history and an exam, and then you can be able to move on from there. Tumors that present in the left side, on the left side, which is the descending colon, sigmoid colon, are the most common, count for about 75% of the cases. They tend to be annular. So this one will give you bowel obstruction, because on one side, the tumors are annular, and then the lumen is smaller. And by the time we're getting to that part of the bowel, you have solid fecal matter. So one of the main presentations is bowel obstruction, and then you'll have colicky pain that's referred to the suprapubic area. You have altered bowel habits, which will be alternating diarrhea and constipation. You have rectal bleeding. You have tenesmus, which is sort of an urge for evacuation, but nothing comes out, usually because of the mass. So you have a feeling of incomplete evacuation, and you have the urge to defecate, but there's nothing that comes out. And then bladder symptoms if there's sigmoid involvement. If the tumor is in the rectum, in the rectal area, you'll have hematochezia, which is fresh blood in stool, early morning diarrhea, mucus discharge, and again, urgency and tenesmus, and a sensation of incomplete evacuation. Physical exam findings, for the most part, in early disease, you might not get any physical exam findings. But in advance, you can get wasting, conjunctival or palmar pallor, because remember, they'll have been bleeding, or they'll come with iron deficiency anemia. You have lymphadenopathy, abdominal distension, a mass that you have to characterize. So it will mostly be, you'll mostly see it again in right-sided. It will be a mass with irregular margins that is fixed. You can get ascites if there's liver metastasis already, abdominal tenderness, and hepatomegaly, again, if there's liver metastasis. The spread of colorectal cancer, you can have local spread, lymphatic spread, which accounts for 90%. So remember, most carcinomas spread via lymphatics, except a few, choriocarcinoma, something else, but most of them spread through lymphatics. So it's the same case for this. And then we have hematogenous spread, which accounts for 10%. Transcelomic, which is basically spread through the surfaces and organs of the peritoneal cavity. And then we have iatrogenic, maybe during surgery, you can cause spread. The most common site of metastasis from the colon and the upper rectum, and you take note, it's from the colon and the upper rectum, is going to be the liver, because they drain through the portal vein. So that's going to be the most common site. For cancers of the lower rectum, because they don't drain through the portal vein, the most common is going to be the lungs through the inferior vena cava. Then other sites of metastasis, you can have brain, bone, peritoneum, and remember lymph nodes, as we had said, lymphatic spread is very common. The workup that you need to do, we have a comprehensive history and physical exam. So comprehensive history, we've talked about any family history of polyps or colorectal carcinoma, or a personal history. You'll need to know about the diet, and then do a thorough physical exam. A digital rectal exam in proctoscopy is very important in this patient. For the digital rectal exam, if it's a distal mass, it may be felt. And you can see if there's evidence of blood, either melena or blood mixed with stool. And then the other workup we'll do is investigations, both lab and imaging. So the lab investigations, if you need to do, we have a complete blood count, because again, as I've been emphasizing, they'll present with iron deficiency anemia. So low HB, and then you have a low MCV and low MCH. And then you have fecal occult blood versus fecal immunochemistry. So now for this, before they used to use fecal occult blood. It's very readily available. So you take you use hydrogen peroxide in order to determine if there's any hidden blood. The problem with that is that you can have colonic bacteria or diet, or you can have plant peroxidases that also degrade hydrogen peroxide. And so its specificity and sensitivity is not very high. And if you compare it to fecal immunochemical tests, which is more advocated for now, where it detects antibodies against globin from the hemoglobin. So even if you have low concentrations of blood, it can be able to detect it without interference from diet or interference from the microbial bacteria. So basically, you've eliminated the disadvantages of fecal occult blood that we had. So it has a higher sensitivity and a higher specificity. But then again, in our context, fecal occult blood is more common. The other thing you'd need to do is liver function tests. Again, if you suspect and to check if there's liver metastasis, a double contrast barium enema to get the location of the tumor, the size, and the relations. So what you'll see is a constant irregular filling defect and apple core appearance or napkin ring appearance. So let me just show you. This is the apple core appearance. It's this non-distensible sort of constriction or narrowing with shouldered margins. So you know how when you eat like an apple, the part that remains with the seed, it sort of looks like that, the top part, the core, and then the bottom part. So this is apple core appearance, and it's what you'll see in double contrast barium enema. It's also called napkin ring appearance. The other test you'd want to do is proctoscopy, sigmoidoscopy, colonoscopy plus biopsy, and histopathological exam. Now, depending on, again, the presenting features, your physical exam findings, your DRE finding. But the preferred, the gold standard is colonoscopy, a complete colonoscopy plus a biopsy and histopathological exam. For a patient who presents with bowel obstruction whom you cannot do for a complete colonoscopy, you can do contrast seating and especially if they have a large palpable abdominal mass. And then you can do a post-op colonoscopy. You'll also need to do CT chest, chest X-ray, PET scan, or pelvic MRI to stage. Now for the CT chest is more sensitive, especially if you're looking for lung metastases. But in resource-constrained areas, you can do a chest X-ray, though even if there are metastases, you might not be able to see them. So ideally, you'd want to do a CT scan of the chest. The tumor marker for colorectal carcinoma is carcinoembryonic antigen. So it's positive in 20 to 30% of the cases. It's used for monitoring disease progress in the treatment effectiveness. So the levels of CEA will correlate with the stage of the disease. The only issue is that it's non-specific, and so we can't use it for screening because it can be positive in other gastric neoplasms, pancreatitis and pancreatic carcinoma, cirrhosis, non-small cell lung carcinoma, smoking. So any one of these can give you CEA. So it doesn't make sense to use it as a screening modality for colorectal carcinoma. You'll need to get a baseline at the time of diagnosis, get a baseline CEA, especially because as I've said, you're going to be using it to monitor the disease progress and if the treatment, and check if the treatment is working or not. Okay. Staging for colorectal cancer. We have two staging types. We have modified Dukes classification, and we have the normal TNM staging that is used for most of the cancers. So modified Dukes classification mostly is to give you a 5-year survival rate. So stage A is confined to the bowel wall. There's a 90% 5-year survival rate. B1, the tumor is limited to the submucosa and there's no lymph node involvement. And then for B2, the tumor is confined to the muscle layer and no lymph node involvement as well. For this, we have a 70% survival rate. For C1, the tumor does not exceed the bowel wall, but there's lymph node involvement. N1, and this is supposed to be N2, sorry. And then for C2, we have tumor that exceeds the intestinal wall, and there's also lymph node involvement. Then D is advanced disease or metastasis to the liver. The 5-year survival rate is less than 10% for advanced disease. The TNM staging, T is for tumor. So T0, there's no evident tumor. And then TIS is tumor in situ. It's similar to the TNM we used to stage other cancers. T1 is invasion of the lamina propria or submucosa. And then T2, invasion of the muscularis propria. T3, you have invasion through into the subserosa. And then 4 is invasion of other organs or structures. Lymph node, N0 is non-evident. 1 to 3 positive pericolic nodes. N2 is 4 more positive pericolic nodes. And 3 is any positive node along a named vessel. So even if you don't have like 3 or 4, as long as you have a node in any of them along a named vessel. So the inferior mesenterics, you'll stage it at N3. Distant metastasis for M, if there's none evident, and if there's any distant metastasis. The management options that we have for colorectal cancer, mainly the treatment is surgical. And then you can do adjuvant, mainly chemotherapy for stage 2, and those at stage 2 that are at high risk of recurrence, and for stage 3. Adjuvant just means you do surgery and then you give chemotherapy after. For metastatic or stage 4, the main treatment option would be chemotherapy. So the main aims when you're doing surgery is to biopsy and stage the tumor, to remove the primary tumor and its draining lymph nodes, to do debulking, to do excision of recurrence, and then palliative, just to sort of give relief, symptomatic relief. So you excise, put a colostomy just to improve the quality of life of the patient, and then also to stop bleeding. The types of surgeries we have, hemicolectomy. So colectomy is removal of part of the colon. So you can have right hemicolectomy if you have tumors on the right side. So ascending tumor, cecal tumor, or proximal transverse tumors. And then extended right hemicolectomy would be the ascending as well as the whole transverse colon. So let me use this image. This is, so a right hemicolectomy would be removal of the cecum and the ascending colon. If you do extended right hemicolectomy, so right hemicolectomy, we've said cecum, ascending colon, and the proximal transverse colon. For extended, you do all this and then plus the transverse. So after you've removed that part of the colon, you do anastomosis from the ileum to now the remaining part of the colon. So you can have right, you can have left hemicolectomy, again, where you remove the descending colon and the sigmoid, the descending colon, and then you can have sigmoid colectomy, you remove the sigmoid colon. Just a bit. And then the other type of surgery that we have is anterior resection. We do abdominoperineal resection for tumors that are less than 5 centimeters from the anal canal. And here you'll have to remove the rectum and the anus, and then you put a permanent colostomy. Okay. And then posterior sagittal anorectal. For a small tumor in the rectum. You can do liver resection in metastasis if you have a single lobe metastasis and there's no extrahepatic spread. If there is, then as I said, the treatment option is going to be chemotherapy. For inoperable tumors, you can bypass. So if it's in the ascending colon, you do an ileocolic anastomosis, you bypass the tumor. If it's on the left colon, you can do a transverse colostomy. And pelvic, you can do a left iliac fossa colostomy. For undergraduate, the main thing you need to know is, especially for this, is depending on where you see, because when you'll be examining the patient, you'll see, especially post-op, you'll see that they have a colostomy. Depending on where it is in the abdomen, you sort of have an idea what surgery they went through or what part of the colon was resected. Chemotherapy, the main drugs that are used, 5-fluorouracil, and then you give plus folinic acid, irinotecan, oxaliplatin, capecitabine. The reason we talked about the pathways, as I said, is that it's going to influence your management. So for the second pathway that we talked about, microsatellite instability or deficiency in DNA mismatch repair, they tend to be resistant to 5-fluorouracil, or they don't respond to 5-fluorouracil. So for those types of cancers, you'll consider immunotherapy. And the biologic agents that we have include bevacizumab, which is anti-VEGF. We have cetuximab, panitumumab, and ramucirumab. So again, remember, high microsatellite instability or an issue with DNA mismatch repair, 5-fluorouracil might not work for you. So you need to consider something else. You can have targeted therapy for certain mutations, such as KRAS. Again, we'll still use the biologic agents. And then for rectal cancer, we can use radiotherapy. So either use it preoperatively to reduce recurrence and increase survival, or to downstage the initially unresectable tumor. So you give chemo first to sort of shrink the tumor, and then you go in for resection. And then you can use it post-op for those that are at high risk of local recurrence, just to sort of cover all your bases. After treatment, the follow-up, patient history and physical exam, symptomatology, are they still presenting with those symptoms, or are they resolving? And then you'll need to do a carcinoembryonic antigen level serum every 3 to 6 months for 2 years, then every 6 months for an additional 3 years. You do CT, chest, abdomen, and pelvis annually, or 6 to 12 months, every 6 to 12 months for 5 years. Colonoscopy 1 year after surgery, then every 3 to 5 years. And the reason why we're so focused on the 5 years is that 90% of recurrences occur in the first 5 years. So if you're able to follow up your patient throughout this whole time, you'll be able to catch any signs or features of recurrence and manage them before it becomes, before it gets to a really bad stage. For screening, you consider individual risk factors. Is there a family history of either cancer, and is it a really close family? Is there history of polyps? Those are the main ones that are easily identifiable. You do a colonoscopy every 10 years. For a normal sort of healthy individual, once they get to age 45, they should start doing a colonoscopy, a complete colonoscopy every 10 years. 45, because as I've said, we're seeing incidence of colorectal cancer in very young individuals, as young as early 30s, mid 30s. So that is the gold standard for screening, but you can do annual fecal immunochemical testing or annual fecal occult blood. And there's also the option of multi-targeted stool DNA test, which is not that readily available. So basically we use colonoscopy and maybe fecal occult blood. This is a normal colon on colonoscopy. We have multiple tubular adenomas in a patient with Lynch syndrome. So remember we said Lynch syndrome carries a 40% risk of development eventually into colorectal cancer. This is familial polyposis. You can see the very many polyps that we have. This one we said carries 100% risk of development into colorectal cancer by almost an 100% risk by the age of 40. And then this is adenocarcinoma. You can see how the areas of the necrotic regions. And this is rectal cancer on colonoscopy. The prevention and my main takeaway is fiber. Eating foods that have high fiber, just for your gut health and to prevent colorectal carcinoma. Eating high content of fruits and vegetables, reducing the amount of red meat that you eat and processed meat. Physical activity. The recommended is about 150 minutes per week. It doesn't have to be strenuous, going to the gym for like an hour a day. No, just even just brisk walking for 30 minutes a day is enough to reduce the risk of so many things, including colorectal cancer. So diet is very important. Exercise is very important. And then reducing, or no, not reducing, stopping or this stopping smoking and heavy alcohol use. Those are things that are modifiable that we can do. We can advise people around us to do in order to reduce the risk of developing cancer. Thank you. I'll take any questions.
Okay, thank you, Jane, for the insightful session. Okay, for the next session at Kahoot, I'd like all of you to join so that we can do a Q&A. I've pasted the link in the group, in the chat box, and the game pin is right there above 339-5818. Kindly let's join. We'll start when the quorum is about 13 guys. So let's join. Kindly let's join so that we can start the session. Okay, let's go. So the first question in a second. So which one of the following is not a risk factor for colorectal cancer? Less than 10 seconds to go. Okay, so 3 of you gave the correct response, which is beta carotene. 2 of you thought it was obesity, but beta carotene was the right response. Next question. So the scoreboard 80 is leading at 910 points, followed by 85 and 824, TYL at 639. Okay, let's go to the next question. So what is the most common site of development of colorectal cancer? Less than 10 seconds to go. And only 2 of you got the right response, which is rectum. One thought it was descending colon, the other ascending colon. Let's see the scoreboard. 80 maintains number 1. A low comes into the second position, 891, and 85 in the third position, 824. Next question. So the most common site of mets from the colon is okay. All of you got it correct. Hello, you're on fire. I see you're still maintaining your position at 2750. Okay, sorry about the technical hitch. So 66-year-old colorectal cancer patient with palpitations, headache, fatigue, dizziness, weight loss, palpable masses, likely tumor location. So less than 5 seconds. Okay, only one of you got it right, which is the ascending colon. Let's see what the scoreboard is reading. 80 excellent at 54.29, still maintaining the first position. TYL second, Alo coming at third. 3 more questions, guys. What is the most common first sign of rectal cancer? Correct. 3 guys got it correct. Bleeding during bowel movement. Let's see what the scoreboard is at. Okay, 80. Excellent at 62.79, maintaining the first position. TYL maintaining second and Alo at third. Let's go to question 8. Okay, what is the gold standard for diagnosis of colorectal cancer? All of you got it correct. Colonoscopy and biopsy of the tumor mass. Second last question. 80 still maintaining the first position. What lifestyle choices decreases the risk of developing colorectal cancer? And 3 out of the 4 got it correct. All of the above: exercise, high fiber diet, increased fruit and vegetable intake. Let's see what the scoreboard is at. 80, still maintaining the first position. Highest streak answer of 9, TYL second, Alo coming in third. Now to the last question. What type of surgery is suitable for tumors less than 5 centimeters from the anal canal? And okay, 2 of you got it correct. Abdominal perineal resection. Let's finalize and see who carried the day. So at number 3 with 34 points, Alo. Coming in second, TYL. And the winner for today's Kahoot session is 80. Excellent, excellent. I'd really love to know who this 80 is. Kindly mute and maybe say hi. Our colorectal specialist. Who's 80? Okay, Ndegwa Mwangi. You are our colorectal specialist for the day. Thanks for that awesome performance. So is there anyone having any questions before we end the session? Any question either to me or to Jane? So this presentation today will be available in our WhatsApp channels and various other XYZZ med channels, YouTube and all that. So you can always refer your friends to watch it later on so that they could learn more. So we have a link in the chat box. You can copy it and share with your friends.